Hello and namaste everyone. Today we'll be talking about the humerus bone. Humerus is the long bone of the arm. Just like any other typical long bone, it has two ends, the upper end, the lower end, and a shaft. Articulations. Proximally, it forms the glenohumeral or the shoulder joint, which is a ball and socket variety of synovial joint, and distally it forms the elbow joint, which is the hinge variety of synovial joint. For site determination, the following points should be considered. The upper expanded head is present superiorly and it is directed medially. Similarly, the intertubercular sulcus is present anteriorly. So, this is the right humerus and this is the left humerus. For anatomical position, the humerus is kept vertical with the head directed medially, slightly superiorly, the intertubercular sulcus facing anteriorly, and the medial epicondyle at the distal end facing medially and slightly posteriorly. Now, talking about the features in detail, we begin with the upper end. The upper end is expanded above the shaft and presents a convex articulating surface or the head. This end also consists of three necks: the anatomical neck, the surgical neck, and a morphological neck. Also, it consists of two tubercles, the greater tubercle and a lesser tubercle, and an intervening intertubercular sulcus between them. The head, which is an example of pressure epiphysis, forms 1/3 of a sphere and is covered by articular cartilage, which is hyaline in nature. It forms the glenohumeral joint with the glenoid cavity of the scapula. As evident, the size of the head of the humerus is much larger compared to the size of the glenoid cavity. Due to this difference, the glenohumeral joint is the most common joint to dislocate in human populations. Anatomical neck. The anatomical neck is a circumferential constriction present between the head and the tubercles, and it gives attachment to the capsule of the glenohumeral joint except inferomedially. Surgical neck. The surgical neck is present between the upper end and the shaft. The axillary nerve winds around this neck posteriorly. Therefore, in the fracture of the surgical neck of humerus, the axillary nerve can get injured along with the injury of the posterior circumflex humeral vessels. Morphological neck. It represents the proximal growth plate and is present ½ centimeter above the surgical neck. Lesser tubercle. The lesser tubercle is an anterior projection of the upper end which gives insertion to a muscle called subscapularis. The subscapularis muscle belongs to the rotator cuff muscles. The rotator cuff muscles forms a musculotendinous cuff around the shoulder joint, giving it more stability. The components of rotator cuff muscles are SITS, which stands for supraspinatus, infraspinatus, teres minor, and subscapularis. Greater tubercle. The greater tubercle is the anterolateral projection from the upper end, and it bears three facets for the insertion of the remaining components of the rotator cuff muscles, that is, the supraspinatus, infraspinatus, and teres minor. This tubercle is related to the subacromial bursa and is covered by the deltoid muscle in the living state. Intertubercular sulcus. The intertubercular sulcus is present between the two tubercles, hence the name. It is also called bicipital sulcus, derived from the term biceps. Biceps means having two heads. It is called bicipital sulcus because the tendon of the long head of biceps brachii travels through it. The sulcus presents two lips and a floor. The two lips are the medial lip and the lateral lip. Talking about their attachments, the medial lip gives insertion to teres major muscle, the lateral lip gives insertion to pectoralis major muscle, and the floor of the sulcus gives insertion to the latissimus dorsi muscle. This can be remembered as the lady between two majors. On the upper ends of the lips, there is attachment of a ligament called transverse humeral ligament, which converts the sulcus into a canal. Lower end. The lower end is expanded and flattened antero-posteriorly. It bears the articulating parts at the center and non-articulating parts on the side. Articular part. It includes a medially situated pulley-like trochlea separated by a groove from a laterally placed rounded capitulum. The trochlea articulates with the trochlear notch of the ulna, forming the humero-ulnar component of the elbow joint complex, whereas the capitulum articulates with the radial head, forming the humero-radial component of the elbow joint complex. The medial and lateral parts of the trochlea are not in the same horizontal plane because the medial part of the trochlea extends 0.5 cm inferior to the lateral part. This osteological design leads to the lateral deviation of the supinated forearm in extension of the elbow joint. Therefore, the upper limbs do not hit the hips during arm swing. It is also important to note that there is an angle formation between the long axis of the arm and the long axis of the forearm. The angle is called carrying angle and the normal value of it is 15 degree in female and 10 degree in male. An increase in carrying angle is called cubitus valgus, while a decrease is called cubitus varus or gunstock deformity. These type of deformities can compress the ulnar nerve or cause other functional limitations. The lower end of the humerus also bears 3 fat-filled fossa, 2 anteriorly, the coronoid fossa, the radial fossa, and 1 posteriorly, the olecranon fossa. During flexion of the elbow joint, the radial fossa receives the radial head and the coronoid fossa takes the coronoid process of the ulna. While during full extension, the olecranon fossa receives the olecranon process of the ulna. Non-articular parts. The non-articular parts consist of the medial and the lateral epicondyles and the aforementioned fossa. These epicondyles provide sites for muscular attachment. The medial epicondyle is a bony projection on the medial aspect of the lower part of the humerus. It is larger than the lateral epicondyle. It also protects the ulnar nerve, which passes posteriorly to it. Bumping on the posterior aspect of the medial epicondyle produces a tingling sensation in the ulnar nerve. The medial epicondyle is also known as a common flexor origin because the flexor muscles of the forearm originate from here. The ulnar collateral ligament, responsible for the stability of the elbow joint, is also attached to the medial epicondyle. Repetitive use of the forearm may lead to medial epicondylitis, also known as golfer's elbow. And also it is interesting to note that the medial epicondyle is commonly fractured in the pediatric population. The lateral epicondyle is a large bony prominence on the lateral aspect of the distal humerus. It is called the common extensor origin because the extensors of the forearm originate from here. Repetitive use of the forearm can lead to epicondylitis of the lateral epicondyle known as tennis elbow. Shaft. It is the part of the humerus present between the surgical neck of the humerus and the epicondyles. The shaft is cylindrical in the upper half and triangular in the lower half. It bears 3 borders and 3 surfaces. The borders are the anterior border, the medial border, and the lateral border. The surfaces are the anteromedial surface, the anterolateral surface, and the posterior surface. The anterior border is the inferior continuation of the lateral lip of the intertubercular sulcus, whereas the medial border is the inferior continuation of the medial lip of the intertubercular sulcus, and inferiorly it extends as the medial supracondylar ridge. The medial intermuscular septum attaches to the supracondylar ridge. The coracobrachialis muscle inserts into the middle of this medial border. The lateral border is hard to figure out on the upper part of the shaft, whereas it is present as a prominent lateral supracondylar ridge on the distal part. The lateral intermuscular septum is attached to the lateral supracondylar ridge, and the radial nerve pierces the lateral intermuscular septum. Similarly, the ulnar nerve pierces the medial intermuscular septum. origins of the muscle brachioradialis and extensor carpi radialis longus is from the lateral supracondylar ridge. The lower half of the anteromedial and the anterolateral surfaces gives origin to the brachialis muscle, and the deltoid muscle is inserted on a V-shaped area on the middle of the anterolateral surface, which is known as deltoid tuberosity. On the posterior surface, there is the presence of an oblique radial groove which runs downwards and laterally towards the anterolateral surface. The content of this groove is radial nerve and profunda brachii artery, and the mid-shaft fracture can lead to injury of these structures. The posterior surface also gives attachment to two heads of the triceps, the lateral head above the radial groove, whereas the medial head below the radial groove. The blood supply of the shaft of the humerus is via the nutrient artery, which passes through the nutrient foramen. The nutrient foramen is directed towards the elbow or distally. That means the upper end of the humerus is the growing end, because the growing end is situated opposite the direction of the nutrient foramen. Ossification. Similar to most long bones, the humerus ossifies by endochondral ossification, which involves gradual replacement of a cartilage model by bone. The primary ossification center appears in the shaft during 8th week of intrauterine life. The secondary ossification centers appears at the ends at varying ages, 3 for the upper end, 1 for head, and 2 for the tubercles for each, and 4 for the lower end, for the medial epicondyle, for the lateral epicondyle, and 2 for the medial and lateral parts of the trochlea. As previously mentioned, the upper end of the humerus is the growing end, and the upper epiphyseal fusion occurs during the 20th year of life. Applied anatomy. The 4 nerves which are directly related to the humerus can get injured during its fracture at various locations. The axillary nerve is prone to get injured during the fracture surgical neck of humerus. The radial nerve can get injured during mid-shaft fracture. The median nerve can get injured during supracondylar fracture, and the ulnar nerve can get injured during the fracture of the medial epicondyle. Moreover, radial nerve palsy can occur due to compression of the radial nerve, which occur in various forms like crutch palsy, Saturday night palsy, honeymoon palsy, etc. Supracondylar fracture is the commonest fracture encountered in pediatric population and occurs due to the fall on outstretched hand. In this fracture, the proximal fractured segment moves anteriorly, compressing the median nerve and the brachial artery, leading to further complication. So, this is a brief osteological description of humerus. Thank you for watching.